In emergency medicine, there are 10 differential diagnoses that must be considered anytime you're caring for a syncopal or a near syncopal patient, and all but one have EKG findings. And there is a mnemonic to help you remember them all: A, B, C, D, E, F, G, H, I, I. So, let's talk about them. A is for aortic stenosis, which is the only one out of the bunch that doesn't have an EKG finding. However, it has a very unique crescendo-decrescendo murmur that you can learn to listen to. B is for brugada, so on leads V1 through V3, be on the lookout for the cove-shaped type as well as the settled back type. As a general rule, it's always a bad thing when you have a T segment that looks like you could sit on it, hold on to the T, and lean back. Some cardiology literature out there refer to this as the carousel horses, so you might see it out there. C is for corrected QT. If it's longer than 500 milliseconds, you could be dealing with paroxysmal torsade. D is for delta waves, so WPW or pre-excitation syndrome. E for epsilon wave, which points to arrhythmogenic right ventricular cardiomyopathy. F for fluid-filled heart, so think pericardial effusion or cardiac tamponade. In this case, you want to look for what we call electrical alternates, which is QRS complexes that get bigger and smaller with each heartbeat. Also, global low voltage on your EKG. G is for giant PE, so look for a new onset of right bundle branch block, right axis deviation, inverted T waves in the anterior septal leads, or S1Q3T3. H is for hypertrophic obstructive cardiomyopathy, so look for high voltage in the lateral leads as well as deep, narrow, dagger-like cues in the lateral leads. The first I is for intervals, so make sure all your intervals are within normal limits. Think about AV blocks. And finally, the last I is for ischemia, so look for ST segment depression or elevation, hyperacute T waves, or inverted T waves in lead AVL, which is oftentimes the very first sign of an inferior wall MI.